Okay, so let's do heart valvular diseases. There's a lot here, more than what we have with myocardial infarction, but it will make sense. I'm hoping I don't cure your insomnia with this, because there's not that many pictures on it. It's like there's only one picture. So I'll do some art therapy up there if you could, for your entertainment value. All right, so the heart valvular diseases, so abnormal valves. So let's go back to this where we talked about it. Stenosis versus regurgitation. So normally what happens here is if this is a valve, right, with the left atrium here and the left ventricle over here, so that's the mitral valve. Normally blood will go through the mitral valve from the left atrium to the left atrium to the left ventricle and do this. So as soon as the blood goes through there, when the left ventricle's pressure is higher than the left atrial pressure, it'll close like that. It'll snap shut. And that's what you're hearing, the lub-dub, with the other valves too. So it's doing this. Now, what's happening with stenosis, and we'll talk about the causes of it in a moment, but what happens with stenosis, it opens like that. It doesn't open all the way. So there's a problem in the opening with stenosis. It's stenotic, we say. So it becomes very narrow. So you could imagine that if it just opens up a little bit, it's going through like a little pinhole. All right, depends on how severe it is, but it goes through a little pinhole. So there's going to be a higher pressure here trying to push it here, but inside the left ventricle, there's going to be less blood there, right? So we could talk about stenosis. We could also talk about regurgitation. And if the mitral valve is supposed to do this, the mitral valve that's regurgitating will do this. So now you're going to have a backflow of blood going into the left atrium. Sometimes we refer to it as mitral insufficiency or valvular insufficiency, valvular incompetence. Okay? So you have a back. So stenosis, you're going to have a problem opening. This one has a problem closing. Okay? And you have a backflow of blood. A single valve can be both stenotic and regurgitate, but for this to happen and the person to actually survive, they can't be severe. Because if it's severe, it wouldn't make any sense because it wouldn't go back. If it's severe, then it wouldn't go backwards. It wouldn't do the other thing. So they're not going to be so severe with that. You could have combinations. You could have a single disease process going on, or you could have multiple diseases going on. Okay, we'll talk about those disease processes in a moment. One valve lesion may cause another one. So if you have aortic stenosis, then you have a vacuum of blood in the left ventricle, and that vacuum of blood over the months can actually cause blood to go through the mitral valve, God bless you, and it can cause regurgitation of the mitral valve. All right, let me just show you a few things here. So we have, and I'm just going to draw, let's say, the left side. I did this last time too. This is the aorta. This. Okay. So this is going to be your left atrium. This is going to be your left ventricle, and then this will be your aorta. Okay? Does that make sense? I'm not going to draw the other side. Okay? We have a valve over here. What valve is that? That's the mitral valve. Good. There's the mitral valve. And then we have another valve over here. And what valve is that? That's the aortic valve. Okay. Does that make sense? Right? So if you have, let's say, if this is stenotic over here, so if we take this aortic valve and we make it stenotic, there's the valve, but there's only a little pinhole there. Then the blood is going to have problems pushing it into the aorta, which means there's going to be a backup over here, which means this can actually go back, and this is actually regurg. So blood can go backwards over here. So that's what I'm saying is that one can lead to another if it's long-standing. Okay? All right. Certain combinations are particularly burdensome. If you have aortic stenosis and mitral regurgitation, as I just showed over here, you can see that that's going to be a big burden on those left ventricle, which will be a backup flow over here, and so forth. Okay? Valves affected. Usually the most common sites are the ones I'm just showing here, which is the mitral and aortic valves. If the tricuspid valve is affected, okay, and it's the only one that's affected, think IV drug users. Because what's happening here is that when they inject drugs in them, they don't have the most sterile needles, and there could be some bacteria on there. The bacteria is going to go into a vein, and what's the first valve that it's going to actually go to? Tricuspid. So if there's bacteria, the bacteria like to be, certain bacteria like to actually glue to valves. They just like to do that, vegetative. We'll talk about endocarditis. And what will happen is it's going to vegetate all on the tricuspid valve. So when you have people like athletes that inject steroids and you have IV drug users, if they have a valve that's going to be affected, it's usually a tricuspid valve. And if you see someone with tricuspid stenosis, think and ask them, do you use IV drug use? Okay? Now that's solely, because you could also have other things, if let's say, if the left heart is also, has like, you know, there's let's say regurgitation of the mitral valve over here, and you've got some other issues on the right side, yeah. But I'm talking about if it's solely the tricuspid valve, think that way, okay? And you hear murmurs. As blood goes through this defective valve, it's going to rumble. It's going to cause turbulence. And that turbulence through a valve is what we call a murmur when you listen to it with a stethoscope, okay? Now, we're going to need to know about different types of murmurs. The only ones I'm more concerned about is a systolic murmur versus a diastolic murmur. So, let me show you what this is. It's not hard if you understand the way that the heart works. Okay. So, we have a normal mitral valve, and let's say it's a stenotic one, right? Okay. So in this case, you have, and we'll talk about the different types in a bit, but we have aortic stenosis. So when the left ventricle is going to contract, it's going through this little pinhole, and that's where blood is going to it's going to be turbulent, right? It's going to move all around, and you could actually put a stethoscope over the area of the aortic valve, or the aortic region, and you can actually hear it very loud there as a murmur. Now the question is this what we call a systolic murmur or a diastolic murmur? Systole means what? The heart contracts or the heart relaxes? Contracts. So, and then when the heart relaxes, that's going to be diastole. So the question is, you're going to hear this murmur, but are you going to hear it during diastole, or are you going to hear it during systole? Systole. So when this contracts, it's going through there, and when it contracts, you'll hear like, does that make sense? Okay? That's what we call a systolic murmur. Now, there's a lot of different systolic murmurs, but aortic stenosis can only be a systolic murmur. Let me show you this one. If you have aortic regurgitation, meaning that this is very floppy. So what's going to happen is when this left ventricle squeezes, it's going to push all its blood through the aorta. And now the left ventricle relaxes, and the pressure here is going to be higher than it is over here. These valves are not going to be able to hold that blood over here. So when this relaxes, the blood is going to go back this way, and you can hear it. So in that case, is aortic regurgitation, would that have a diastolic murmur or a systolic murmur? Diastolic, because it's going to have, blood is going to go through here and hear that murmur during when the left ventricle relaxes. Does that make sense? And you can do the same thing with a mitral valve. I'll let you guys do that on your own. But it's the same thing. Is it during ventricular contraction, or is it during ventricular dilation? Or not dilation, but relaxation. Right? So that's what I'm saying is with all that. Does that make sense? You need to know the blood flow through the heart to understand all about these valvular diseases. There's no way. Don't even look at the valvular diseases if you don't know blood flow through the heart. It won't make any sense. Okay? All right. So, complications of both types of valve diseases, it'll increase the cardiac work. As I just said, if this is going to be, I'll leave this one here, aortic regurgitation. That means blood is going to go back here. Now, let's look at this. If you have normal, and I'm just going to give you numbers so you can just, it's easier to work with. If 100 milliliters of blood is going through here, and it goes into the aorta during one squeeze, but now you've got aortic regurgitation, 20 liters comes back, or 20 milliliters comes back. So now this heart is used to pushing out 100 milliliters, but now you're going to put 120 milliliters. And that gradually gets higher and higher and higher. That's going to increase the cardiac workload. Does that make sense? And the same way with stenosis, with mitral, and all that stuff. Okay? You will increase the volumes and increase the pressures in the cavities, as I just showed you over here. More blood is going back here, there's more pressure in here. Okay? I just showed you one valvular disease where it's aortic regurgitation, but it happens with all the other ones. Not with the left ventricle necessarily, but it could also happen with this cavity also. Okay? All right. And we have these compensatory mechanisms. All right? Because the heart needs to pump the blood. It wants to try and get the cardiac output so that the whole body gets perfused. So the heart is going to try and come up with mechanisms to do that, to try and withstand the amount. If there's going to be more blood going backwards over here, then this heart has to try to compensate by getting larger. Does that make sense? So it's going to dilate so it can withstand that extra amount of blood. The other thing, too, is that since it's got to push more blood that way, then the muscle mass is going to increase. So you're going to see ventricular hypertrophy, right? Just the same way, if I have to lift, let's say, 10 pounds, now you're going to give me 50 pounds. If I do that, I'm putting more work, my muscle's going to get bigger. It's the same way over here. All right? We clear with this so far? It's not hard. The heart is wonderful because it just makes sense. Okay? Heart failure will eventually occur because of overwork. There's going to get to a point where this left ventricle is just going to get so big it can't dilate anymore, it can't get thick enough. Eventually, it's going to cause heart failure and get it back up here, and so forth. Okay? So how do you diagnose this stuff? Well, you do it clinically. Like I said, you listen to the heart, clinically at the bedside, you listen to the heart, you hear these murmurs, you see if it's systolic, diastolic, you get some idea. See what the person has, if it's shortness of breath, that kind of makes sense that there must be something wrong with the valves. Not necessarily, but there's got to be something wrong with the valves if there is on the left side, not on the right side, right? That kind of thing. So it's clinical. The other thing you could do, too, is do an echocardiogram. A lot of people call it echo for short. And all this is an ultrasound of the heart, okay? And what it's going to do, you could also do a lot of things with an echocardiogram. You can actually visualize the chambers, you could visualize the amount of blood that's in there, the ejection fraction. But one of the other things you could actually do, too, is that it actually best depicts the valves here. So if there's any question about valves of the heart, they're going to order an echocardiogram and rule out valvular disease. And you can see if there's any vegetations, if there's stenosis, and so forth. Okay? How do you treat them? Most cases, it's just going to be a valve replacement. Okay? If there's stenosis that's going on there, they could put a balloon, okay, where it's balloon valvuloplasty. They could put a balloon in here, not for this, but more for stenosis, to try and open it up. And there's a picture of it over here where you put the catheter in, over here, let's say it's stenosis over here, and then you blow up the balloon, and it should open it up a little, okay? So I'm not going to ask you about in terms of like, when would you use this or that, but you should have some idea of what's going on with that. All right, so let's talk about endocarditis, bacterial or infective endocarditis, okay? Bacteria is usually staph or strep that's causing this, all right? And it usually will do the inner lining of the heart, the endocardium, right? The endocarditis. Well, the valves are a part of the endocardium. So what will happen is all heart valves are at risk for this. As I just explained to you before, with someone injecting, drugs, IV drug use, that if there's bacteria there, it's going to then go to the first valve, which is going to be the tricuspid valve. So all hearts will do this. okay, or all heart valves. So patients need, if someone has a valvular disease, whether mitral stenosis or aortic regurgitation, any of those, they're going to need to be put on prophylactic antibiotics before they do certain medical, dental, or surgical procedures. The theory on why we're doing that is because if you have to get your tooth removed, there's a lot of there's a lot of bacteria in the oral cavity. So if a tooth gets removed, theoretically, some of that bacteria could enter any kind of open blood vessels that you just removed the tooth, and it could go into the bloodstream, and then it's going to go into your heart, and that particular bacteria is going to start growing and cause vegetation on that heart valve. And that's why we want to do some kind of prophylactic antibiotics for that. Okay? If we don't treat this, if the person has endocarditis, they will die. Okay? So this is a picture of a heart valve. I forgot which one it is. It looks like either tricuspid or bicuspid valve. But this is vegetation that's going to be on there. So you can see where that builds up. And that can cause some kind of stenosis or something. All right, rheumatic fever. This is an autoimmune disease, but it doesn't start off as an autoimmune disease. It actually starts off as a bacterial infection. Okay, usually children 5 to 15 years old has this. It usually occurs about 2 to 6 weeks after they have Group A streptococcal pharyngitis. What is that? Strep throat. Okay. What happens here is that it usually happens afterwards, and your body starts making antibodies against this thing. The pharyngitis goes away, the strep throat goes away, but you still have these antibodies that are just floating throughout your whole body should you ever get this bacteria again, so they always remember it. But these antibodies, the anti-strep antibodies, will start coalescing on the heart valves and start attacking the heart valves. And when it does, it can cause all these different valvular diseases. Other things that rheumatic fever will cause is obviously just by the name. You have a fever, a certain rash. Migratory polyarthritis is basically, they have arthritis. They get arthritis in certain parts of their joints, but in many parts, and that's why it's called polyarthritis, because it's not just one place, but it migrates. So you may have, let's say, arthritis in the knee, and then it goes away, and then you got it in the wrist, and then it goes away. It goes from one place to another. It migrates. They will usually have what we call rheumatic heart disease, or better known as myocarditis. We'll talk about that. Pericarditis, and of course, valvulitis. Okay? So we just have to, it's an autoimmune disease where it attacks the heart valves, and it could cause these kinds of things.